So our next two speakers are here to talk about system transformation, something that was alluded to earlier this morning. It's easy to put a nice clean slide with diagonal arrows across the health system and talk about integration. These two have been working hard with many others to make this happen in with the Vancouver Stop pilot. Scott Harrison is currently the Director of HIV/AIDS and Urban Health at Providence Healthcare, and I think that he's a super nurse, is kind of how I think about him in particular. He has a long clinical background working with Indigenous and marginalized communities. Are you still the president of CANAC?
I am.
And currently the president of CANAC? Chris Buckner, currently the Regional Director for Prevention for Vancouver Coastal. He's been involved in many initiatives that have been those intersections between health, social justice, politics, community, one of the most prominent being working on the development of supervised injection services in Vancouver. He's a trained social worker, public health sector management as well. I think we should make him an honorary nurse, is kind of what I think as well. And so pleased that both of them are here today to talk about the sleeves rolled up work around systems transformation.
We're a little bit like a L'Oreal commercial. You've heard the science, here comes the experience. Our purpose in this plenary session today is to give you a bit of a crash course introduction into why we're all here today and why we need to work together as a community for continued change. BC has been provided with a unique opportunity, funding, the holy grail of healthcare. But it also gives us as healthcare professionals and community workers an enormous responsibility because it's not just about doing more testing and getting more people on treatment. We're being tasked with, we've been asked to change the course of the HIV epidemic in BC and change the way that HIV is viewed, discussed, and managed, and bring about the start of the end of HIV. We're not here as Vancouver Stop to tell you how to do it because your systems, priorities, and communities are greatly different to ours and reflect the huge diversity of our province. We're here to share our learning, to tell you what we found, what we did wrong, and what we got right. As Chiro introduced me, I've been an HIV nurse for 20 years now. My secret's formaldehyde, if you were wondering. And at the start of my career as an HIV nurse in 1992, when I graduated, a positive test, which I gave frequently, was an assured death sentence. And much of my clinical focus was in an intensive care unit, managing age-related health crisis and providing end-of-life HIV care to far too many bright young people. Throughout the STOP pilot, colleagues from across the country, particularly my nursing colleagues in CANAC, have asked me, what have you learned in the last 3 years? And I really do wish there was an easy answer to that. The most startling lesson was that everything you think you should do and every early plan you should make should go straight in the shredder. Most of what we planned was based on the old paradigm and was viewed through a lens of bolstering our existing services. My patients, colleagues, and most importantly, our community in Vancouver has taught me over the past 3 years that we start by considering what led us to this point. We can't forget what has happened, and we can't look away from what is still happening to our communities. We've not heard today much yet about the context of HIV, so here's a little history.
Plague! We are in the middle of a plague! 40 million infected people is a plague!
AIDS is now the leading cause of death.
Demonstrators blocked access to buildings.
Coalition of gay groups came to shut down the FDA.
This government has the resources to deal with the AIDS epidemic, and they won't do it unless we force them.
We want everybody to join us. We are trying to arouse to anger and action.
Until we get our acts together, we are as good as dead.
I started to look for treatments to help save my life.
I wish they'd shut their mouths and get their mentality out of their crotches.
There was nothing coming out of our government's efforts.
But no, they march in the streets. They defy you.
I decided to become a full-time AIDS activist.
They all had to become scientists to some degree.
We can take a drug, your test tube, to the market in under 2 years. This total reluctance on your part is going to get you nowhere. It'll end up killing us.
The death rate just kept on climbing.
It became very clear that you weren't going to mess with these people.
I am going to fight them. My patients are going to fight them. And you goddamn well.
We need our government to save our lives. This isn't going to be cured for years and years and years. I'm going to die from this.
Someday, there will be a people alive on this earth who will hear the story that once there was a terrible disease and that a brave group of people stood up and fought, and in some cases died, so that others might live and be free.
The legacy of this activism is misunderstood if we imagine HIV at the individual level is just a matter of getting more drugs to more people. In the face of massive despair and loss in the early years of AIDS, attempts to grapple with the effects of an epidemic shone a powerful light on the structural problems of our society. We witnessed firsthand that even if you were once isolated from poverty, discrimination, racism, or heterosexism, acquiring the virus pushed you into the margins of society and away from everything that kept you safe and sane. It was clear that not just individual lives were being destroyed by HIV, but whole vibrant communities were being decimated by social indifference. People living with HIV, activists, everyone who fought AIDS, named those things were wrong and formed new coalitions across race, class, gender, and region. Communities fought back, took care of each other, and often through unexpected coalitions, and always with extraordinary courage. HIV still reveals the poverty of our social values and the intransigence of the structures that impose those values. Whilst pharmaceutical advances and medical technologies continue, those efforts will add up to very little if laws, policies, and social attitudes go unchanged. Now more than ever, it's critical to ground HIV prevention and treatment efforts in a social justice framework that genuinely engages the desires and perspectives of people who face the structural opposition and oppression that put them directly in harm's way. Idle No More is a current example of activism against this impression, and I, for one, am idle no more. We must be mindful that community tolerance of HIV is directly impacted by the media and legal systems, which are both in Canada saying very loudly and clearly that responsibility for health lies solely with the person living with HIV. This risks bypassing education and all the professional advice that we give regarding social and personal responsibility for our actions, and it creates a fertile dialogue for shame around HIV. As we plan provincially to address HIV in BC, focus and intention are required to ensure that those whose voices are not often heard are given the space and support to be fully included in this dialogue. As health professionals, we know the benefit that modern medicine has provided to people living with HIV, but we must also ensure that we don't lose sight that a person lives with the virus and not the other way around. With the advances in diagnostics, treatment, and care for HIV, we often, or try, to forget about the devastating impact this infection has had on our communities. In order to confidently move forward, we need to reflect on where we've come from. Advances in HIV have come very quickly, possibly faster than in any other disease known to man. While these advances have come with the support of government funds and through the hard work of many researchers and clinicians, these advances were fueled and often forced by the sorrow, anger, and passion of thousands of people who have lived and died of HIV and their families and friends. The collected grief that resulted from the death of an entire generation of gay men, from the First Nations communities and families of people living with addictions that have been severely impacted, this grief continues to fuel the ongoing work that transforms our approach to HIV. This grief and anger that transform the way that we diagnose and treat HIV can retrospectively be understood through the theory of collective impact. It describes not only what occurred, but why it was so effective and how we can leverage our systems by applying these 5 key principles. Sometimes intentionally and mostly unintentionally, our experience in Vancouver Stop over the past 3 years was also shaped by these principles. A common agenda, the clear goals that are shared among all the participants of the Stop HIV project, and From Hope to Health is now our blueprint and our common agenda. Backbone support by building an expert project team and resourcing their roles appropriately. We simply would not be where we are today without our project team. Without skilled project managers, business analysts, clinic analysts, evaluators, and epidemiologists, we would have been truly lost. Mutually reinforcing activities describes the influence of all the pilot's initiatives and the fact that they were all very, very different. They supported and reinforced one another by taking on various parts of the continuum of service. We used the client journey as a framework that helped us to roll the activities and demonstrate how each activity played an important role in meeting different project goals. Continuous communication was essential, and whilst we didn't always do well as we could have, transparent and timely communication across all the partners has been absolutely key to motivating our efforts, maintaining trust, and ensuring that everyone felt very connected to a common agenda. And shared measurement. A robust monitoring and evaluation framework supported us in focusing a large number of diverse participants on a common goal and also helped to hold all of us accountable. And where are we today? It is remarkable how far we've come. The opportunity and the evidence and epidemiology presented this morning would have sounded like science fiction just a few years ago. For other provinces, our progress in BC and the commitment of politicians and healthcare providers in our province remains awe-inspiring. It's remarkable to be living in a time where we can accurately describe HIV as a manageable chronic condition and can be reasonable in our hope for an AIDS-free generation. The Hope to Health document sets a target for 0 AIDS case reports by 2016 in BC. That is a truly remarkable transformation. It's a big ask, but it is achievable. And we have come so far, but we're far from done. Here's a list of some of the recent admissions to 10 Charlie, which is the HIV acute care unit at St. Paul's Hospital, which is unique to Canada. It's remarkable that the list of HIV-related conditions that are up on the screen now are largely treatable. But we still see these conditions far too regularly as a result of people being diagnosed far too late. If you think, anyone in the room, that provincially this is not my problem, this doesn't occur in my region, I'll give you an example. About 3 weeks ago, just after Christmas, with flu impacting our workforce terribly, I returned to the floor for a day as an RN on 10C on my inpatient unit. My assignment as a nurse that day was a weird snapshot of our province. A 35-year-old male from Interior Health with cytomegalovirus and encephalopathy. A 50-year-old from Fraser Health, newly diagnosed with HIV and neurosyphilis. A 46-year-old male from Northern Health with HIV-related wasting and Kaposi's sarcoma. And a 56-year-old from Vancouver with HIV-related lymphoma. Each of these patients represents a list of missed opportunities for diagnosis.
So we eagerly began our planning, and we started getting busy. And we started making plans to do more of the same thing that we'd been doing for the previous 10, 20 years. But now we had money, so we could do them bigger and faster. But we were still running down the same road that we had been running down before. We were increasing hours of testing clinics. We were doing outreach testing throughout the downtown east side. We were expanding capacity of specialized clinics around town to do treatment and engagement for people with HIV. And we got very busy, and we were waiting with anticipation for the data to tell us of our impact. We were playing around the margins of an old approach. and we found that we were having a marginal impact. Our testing, our diagnosis, treatment numbers increased slightly, but nowhere to the extent that was needed in order to significantly impact the course of the epidemic. And that's what was expected from us, and that was our accountability with this opportunity. So our leadership team, we were at a loss. We were committed to the work, but we became aware that none of the strategies that we were investing in, while important, would be adequate to meet the mandate of this project, a transformative mandate to change the course of the HIV epidemic. We had a few dark nights of the soul, those mattress grabbers where you just can't sleep. What have I signed up for? And we had a number of strategy sessions where we realized that in order to be successful, we need to let go of much of what we thought was the standard gospel in HIV work. And that we really needed to be clear and honest with ourselves that it wasn't about doing more of the same, but actually transforming the system of care. So a lot of this work became about transforming our understanding of who we served. It's a pretty simple focus to think about serving an individual versus serving a population, but really engaging in this and understanding what it meant for us supported a radical shift in our planning and our practice. This shift forced us out of an accountability paradigm that we'd been most familiar with. We typically felt ourselves accountable to the people that showed up to the doors of our clinic. And if they didn't show up, it wasn't our problem. Maybe they'd show up somewhere else and it was someone else's problem. We also had to look beyond the boundaries of traditional service delivery methods. And we had to acknowledge that everyone was our client, the entire population. Some implications of this included the critical nature of a population-level monitoring and surveillance framework. When your client is the entire population, surveillance data become your clinical information. We were forced to look beyond the traditional service delivery models and programs that only succeeded in reaching smaller segments of the population and look to wider access models. For example, previously, HIV testing has been something that largely has been done by specially trained people delivered to special populations within special programs. We really need to look at the opportunity to shift that and have every access point to the system of care be a place where testing and diagnosis could take place. Acute care, primary care, family practice, mental health teams, addictions treatment, jail, abortion clinics, all of this have to become access points to testing and diagnosis. We were forced to look beyond the walls of our programs and organizations. Previously, VCH Community Health Services could ignore issues in acute care as they were other people's problems. Capacity issues could be other people's issues when a program was full. And most fundamentally, VCH and Providence Healthcare acknowledged that as organizations, we provided segments of a system of care to a common population. But we weren't talking as much as we needed to actually deliver an integrated system of care. So we came together, we pooled our dollars, we collapsed our structures, and we integrated to actually provide a way to serve a population. Furthermore, we're beginning to implement initiatives across programs, having engaged over 100 physicians in family practice in this initiative to date. While there are many tools and strategies that we've embraced in the pursuit of system transformation, I think probably the most critical or foundational has been the establishment of comprehensive monitoring and evaluation framework. As previously mentioned, surveillance is the diagnostic tool and clinical information of a population. When we began, we had little more than a press release to inform our goals and accountabilities. There was a very compelling idea with mounting academic support, but none of us really knew what was meant by going out there and doing treatment as prevention. So by using the available data, we were able to analyze the current performance of our testing efforts and our treatment efforts. We were able to identify both some very important gaps and some clear achievable goals and targets. By developing a monitoring and evaluation framework, we were able to take a compelling idea and turn it into specific targets that informed specific strategies. It became our roadmap. By taking our population-level indicators and targets, we were able to also develop program-level goals and indicators targets that were in alignment with those overall goals. So our strategies flowed directly from what we were monitoring at a population level, which flowed directly from the overall goals. This also helped us be really clear with our partners, contracted agencies, our programs within our organizations, in understanding what our individual accountabilities were and what the scope of what we had to do was. Everything that we were doing had to roll up to this common framework and to that common goal. We were able to understand, to use this to develop performance agreements, contracts, and memoranda of understanding that were clearer and better understood than any we'd been using previously. It also supported us in treating our direct health authority programs in the same way we were treating contracted agencies, which was different. From this, a common culture among participants has begun to emerge. This is hard work, but we're able to have conversations with these partners and understand collectively what we're accountable for and what each of our role is in delivering that. So here's an example, and you've seen a version of the slide earlier, but an example of how we used the available data to analyze our system performance. This analysis was key for us in that it showed that despite being very busy with the volume of tests being performed, we were actually doing a substandard job in diagnosing people early enough in their infection. In fact, you can see that more than 60% of the individuals had been diagnosed with a CD4 count of less than 500, past the point at which, under current treatment guidelines, they should have been prescribed antiretroviral therapy. This is a key reason our individual outcomes were not optimal, and it's most certainly contributing to onward transmission in the population. When we looked at these data, it became crystal clear to us that we would not be able to achieve what was needed by simply doing more of the same. By continuing to offer HIV tests only to those who identified themselves to a healthcare provider as having risky sex or having used drugs unsafely, and have the efficacy to actually get to some of these testing programs and have that difficult conversation about risky sex or drug use with healthcare providers, we were actually not providing optimal access to diagnosis to the people who needed it. But what do these data mean for people on the ground? Of the 37 people we've diagnosed in acute care over the last 18 months, 4 were diagnosed too late for treatment to be of any benefit, and they died upon that admission. These are not abstract performance targets, but represent current deaths that could have been relatively easily prevented with improved efforts to test early and diagnose and provide care. This is another example on this slide about how we've used data to transform our approach in the way that we were, in the way that the system needed to function. This is analysis that we refer to internally as our missed opportunities analysis. So what it showed in an analysis of previous diagnoses in previous years was that of the new diagnoses, 1/3 of the patients diagnosed in the past 3 years, had at least one outpatient lab, ER, or inpatient encounter. But specifically, of those diagnosed late, 60% had at least one opportunity to be diagnosed earlier. The mean number of encounters was 4.63, with 51% of those having had lab work. So not only were we diagnosing people significantly late in the course of their infection, but those who we did diagnose had several encounters at which they could have previously been diagnosed, but they weren't, because we weren't offering them a test. Clearly, the system that had been functioning wasn't bringing the care to the people at the time and the fashion in which they needed it, in order to give them the best chance for health and to prevent onward transmission. There are many stories behind the data in this slide, but one of them is of a relatively young man who had experienced over 80 pounds of weight loss. For a year, he'd been engaged in care, and a whole host of diagnostics had been run, but an HIV test was not one of them. Eventually, many months later, he was tested and diagnosed with HIV, but unfortunately, this happened too late to prevent his death. Had the test been offered, and had he been diagnosed months earlier, this man could have been returned to his family and his children. We've also used policy and seen how policy changes can transform the way that our system of care works. As we spent some time remembering, HIV was a vastly different disease 15 or 20 years ago. And initially, with no effective treatments to offer anyone, and when effective treatments came, they were complicated with serious side effects. So being diagnosed in those early days came with little benefit for somebody other than to allow them to plan for certain death. And this was the context in which many of our previous HIV testing policies and frameworks had been developed. In healthcare ethics, it guides us to develop policy to take into account where the balance of benefit can be found. So in the early days, because there was very limited benefit to be diagnosed early, the policies rightly focused on identifying all the harms that might arise as a result of a diagnosis. And we had a very rigorous and often long process of pretest counseling. Today it's different, and we need to and have updated our policies related to HIV testing, because we have treatments that can keep people healthy and support them to lead full active lives and vastly reduce the chances of onward transmission. So the balance of benefit relative to HIV testing has shifted, and we've in fact in recent years shifted guidance provincially regarding pretest counseling. It's been updated to promote informed consent conversation that's more tailored to the current benefits and harms related to testing and individual patient need, and is allowing us to remove some of those barriers to actually ensuring that HIV testing is offered across that system of care. Additionally, we've seen a general shift from almost exclusive patient-initiated approach to that puts some of the responsibility on the shoulders of the provider. We've seen how a system requires patients to test. We've seen how a system that requires patients to request a test leads to missed opportunities for our diagnoses and the poor outcomes associated with that approach. But as you can see here from this quote from the College of Physicians and Surgeons, they've acknowledged that this as well, and that stating that missing the diagnosis is not acceptable medical practice today. We've also had to really look hard at ourselves as leaders, and what does transformative leadership mean? We often perpetuate barriers to system transformation. We have big demands and accountabilities placed on us, leading us to focus on what we need to do just to get through the next day, the next week, or the next year. We lose sight of opportunities to make true population-centered and sustainable change in the system and find out ways to radically improve outcomes. When we're stressed out, it's too easy for system failures to be the part of another program, another health authority, or the fault of the government. But this sort of thinking perpetuates the status quo. We are being given an opportunity here. These are new dollars. There are new paradigms emerging, and these open up the potential to work differently across programs and agencies. And the potential payoff is the biggest prize of all, to make a real difference in the health of our populations. And this is really the only reason we come to work every day. There's a couple other important systems change that we made that I'll go over quickly, if I can find my notes. The first of which is looking at how we're taking a fractured system and moving to much more of an integrated system of care. Our overall system of care is delivered in program or organizational silos, and this is true of the HIV service delivery. It's been fractured, and there are AIDS service organizations with each having their own mandate, niche, and family practitioners delivering primary care, specialists, community services provided by the health authority, housing providers, food providers, mental health and addiction services, Aboriginal health services, etc. Our old way of working was to focus primarily on our direct health authority services. Contracted agencies were often ignored and not invited to the table as important partners in care delivery. Family practitioners were also seen as external operators with whom we had infrequent contact. Often in health authorities, we'd forget that we only provide a small slice of the system of care, and that by acknowledging that our commitment isn't to the entire population and that we have to focus on the entire population to make this difference, it really forces us to look beyond these silos. Some of the ways that we've tried to do this, and again, this is tough work, and I don't want to say for a second that VCH and Providence have got this dialed or that we've fixed this problem, but we've identified it as a problem that we're trying to overcome. We hold service provider meetings to bring together all providers across that system of care so that we can plan collaboratively and share information and progress. We've begun integrating care rounds across Providence and VCH, public health and community care. And we've actually developed a structure that requires collaborative care by having a centralized group of clinicians on our STOP team who are embedded across several programs and agencies. Individual programs have support, but a common team to come together across several programs to work on practice, share clinical information, and strategize on difficult cases. This piece about moving from adversaries to collaborators flows from some of that idea as well. And perhaps it's because of the history of activism, but most likely it's also because of the power imbalance between health authorities and the big bureaucracies and smaller service providers that are contracted. But far too often, we've perpetuated that power imbalance and haven't invited all people to the table. Explicitly acknowledging the different roles that each of us play in delivering the system of care has to be part of that, and bringing every partner to the table and allowing advocacy to happen and recognizing it as a true voice that people are playing on behalf of their constituents, and not a way that they're just that advocacy impacts on us in making our day tougher to have to respond to it, but actually understanding that from that tension, benefit comes forward. And this is how we've moved the system forward in the past. We also have tried to move from secrecy to transparency in some ways. Again, this is hard work for an organization like a health authority, and it's ongoing challenging work, but it reaps many benefits. By intentionally sharing all the information that we have and naming what we don't will help bring that trust and encourage that collaboration. If we don't tell people who we are and what we know, they will invent it, and it's not going to be a good story. We've also changed our accountability mechanisms as a way to try and bring forward system changes. We have decided that in this project, we don't treat our contracted partners any differently than we treat our internal programs. We develop accountability mechanisms with the same sort of metrics and the same sort of accountabilities that roll up to a common framework. We developed 6-month memoranda of understanding or contracts, both with our internal programs as well with our external service providers. And this allowed us both in a way to manage scope and focus people truly on what the goals and targets of what was happening, but in evaluating these on a 6-month basis, it allowed us to stop doing things that weren't working and shift things very quickly into moving forward and trying new things. Lastly, we made an intentional shift on how we thought about the roles on our care teams. For years, we had peer programs and peer positions involved in delivering our services, but far too often, these were token positions. Peers were given less important work. Through STOP, we have had the opportunity to work with Positive Living BC and others to identify roles for peers that were integral to the delivery of care. The Peer Navigator program embeds peers as members of our care teams in a variety of settings and gives specific responsibility for supporting learning and treatment readiness among diagnosed people, newly diagnosed people. There's a lot of challenges to system transformation that we've experienced along the way. HIV is an intensely stigmatized condition. Because of its association with sex and drug use and how it impacts marginalized communities disproportionately, it's difficult for patients to discuss and challenging for bureaucratic organizations like health authorities to prioritize. Often, stigma leads us to disregard the compelling rationale for action or prioritize efforts that have impact on our communities who are marginalized. Let's reflect on how readily we embrace other public health strategies. In 2011 in BC, there were 268 diagnoses of tuberculosis, and there were 289 diagnoses of HIV. In most health authorities, there were more HIV diagnoses than tuberculosis. We also have invested over the last few years in public health. My colleagues who deliver public health programs and other health authorities will be familiar with our vision screening programs. And we've been very successful in approaching almost universal access for vision screening and have put a great deal of effort into these pieces. And I don't mean to set up false comparisons between diseases or conditions here, but I think when we realize that, on average, through HIV screening, we can add an average of 16 years of life per infection diagnosed. And we have the opportunity to eliminate onward transmission. But yet we still struggle to engage our leaders in the type of serious system change that needs to happen to realize these benefits. I think we really need to seriously ask ourselves, why do we embrace some strategies and why are we resistant to others? And what's behind some of these prioritizations internal to our organization? Another significant way in which a significant challenge to system change is failure to recognize that we don't know what we don't know. We've all heard people say, and we've said it ourselves, that we don't have HIV in this community, or we don't have these sort of people here. But how do we know this? PHAC tells us that 25% of people with HIV are unaware of their infection. So given this, how can any of us look at our current diagnosis rates and make any valid assumptions of where people with HIV live? We had no clue that we diagnosed 37 people in acute care when we began offering HIV tests routinely in acute care. And we had no idea that of the people that we offered that test to, that on average 94% of them would accept that offer of an HIV test. We had to try it in order to find these things. And I think this is really the only reasonable way to go forward in trying to transform the system and really be clear that we don't know what we yet don't know, and be rigorous about trying and courageous about trying some new things and using data to actually inform what the successes and what the real challenges are there. There are a lot of sacred cows across healthcare, but specifically in HIV, and I think we really need to name those and not be afraid of naming them, and risk sometimes shunning by our colleagues who have historically invested very deeply in some of those norms, and really today look at those and understand, do they continue to be valid? Are our policies related to HIV testing still as valid as they need to be? Unless we explore these questions and these beliefs, we run the risk of simply perpetuating the same system and producing the same inadequate results. Lastly, we need to really address fear and inertia as the barriers to change. It's scary to take risks, and we're not often rewarded in the bureaucracies that we work in for taking bold risks. We're often quite rewarded for kind of hiding and ducking and making sure that we just get through the next day or the next week and otherwise. So we need to, unknowingly, this is the trap we fell for when we began this project. We started by doing more of the same and desperately tried to tell ourselves that if we only did more and did it faster, that we'd succeed. But it was very difficult for us to move out of the comfort of those familiar paradigms and identify what truly needed to be done in order to meet the project goals.
As we've discussed, HIV is often compared to other chronic diseases, and medically it may be. But sociopolitically, it isn't like any other chronic disease. It holds a unique sociopolitical context, and that has to be acknowledged and addressed if we are going to make real progress with HIV in BC. Social determinants of health, including racism, poverty, housing, food security, treaty rights, Aboriginal social conditions, and social exclusion, all have a direct impact on the risk of HIV transmission. Drugs alone will not solve BC's HIV epidemic, nor will apportioning blame or simply asking people to change their behaviours. The old paradigm for HIV care we have seen has limited benefits. Behavioural changes include the systems that provide care and the structures within society that support that care, and certainly within healthcare itself. The history of HIV demonstrates that when communities and people living with HIV, government and healthcare providers come together, huge strides forward can be taken quickly. Our response in healthcare is often to do more of the same and expect a different outcome. We're not particularly bright when it comes to change. Stop HIV has given us a unique opportunity to effect a paradigm shift and make real changes to the way that prevention and treatment are delivered and how individuals and communities have been engaged in their own care. The philosophy of lean healthcare, our most recent fascination, is that frontline workers know what is needed to make their work most effective. The same holds true for our communities. The healthcare system, and particularly our chronic disease model, are designed to be transferable across a wide range of disease processes. And whilst many of the key principles are applicable to HIV, we can't simply use them as a direct transfer template. HIV carries with it the stigma that is unknown to heart disease, diabetes, or chronic obstructive pulmonary disease. HIV is still not seen as a victimless disease, but is intimately tied to very uncomfortable social activities like sex and drug use. it still carries with it the false belief that I'm not like that, it could never happen to me. Our system of care sprang, as we've discussed, from early activism and was led by grassroots community responses. And these responses created AIDS organizations that were often the only option for people who were infected with HIV. Healthcare was largely reserved for the experimental treatments and the treatment of opportunistic infections and monitoring people as they slowly died of AIDS. This paradigm, sadly, has stayed with us. Responses to HIV became a less deliberate process, and the belief that now treatment is available to all British Columbians, we had it in the bag. But the current system is not working effectively. As Chris pointed out, it remains an alarming fact that 30% of people dying from HIV in BC have never received HIV care. During our pilot programs, we bore witness to the large numbers of people who've been diagnosed late into the disease process and were very much unaware of their status. We have to consider provincially that stigma around HIV is the Berlin Wall of our province. It's man-made, much like the Berlin Wall, and it was created to separate us from a perceived threat and is based on a very much outdated worldview. Like the Berlin Wall, stigma requires a visceral human response in order to dismantle it. Step one is moving prevention and testing out of the realms of perceived risk and making it accessible and acceptable to the wider community. Whilst focused, intentional prevention is required with communities who share a greater burden of risk, so is general, widespread screening. A key message for the community and healthcare providers is that early diagnosis and treatment matter, that they are the primary indicators for positive outcomes. And to leave you with a more hopeful vision of the future, we're bookending with a video that was created as part of our work in BC to try and promote the fact that it is different now, that HIV has changed, and to promote the public to come forward and get tested.
How do you change history? You can change history by walking and marching. You can change history by speaking and teaching. You can change history by taking a stand or taking a seat. But the best way to change history is when you becomes we. We tore down that wall. We marched for equality. We made sure that love knew no boundaries. Now you can become we right here in Vancouver. We can end HIV. We can change history. Sounds impossible? It's actually really simple. It's all about telling everyone that HIV is different now. You probably still think that HIV is a terminal illness, but it's not. If you catch the disease early on and start taking the prescribed medication, you can live a near normal life. The advances in treatment now allow an HIV-positive partner to live a full life with a partner who is negative. In fact, a person living with HIV on treatment could be up to 96% less likely to transmit the disease to a sexual partner. In some cases, that medication can be as little as 1 pill a day. And if we can stop the transmission, we can stop the disease. It begins with a test. Testing today can range from a blood test that'll inform you in about a week to some locations where a prick of the finger gets you a result in 60 seconds. Diagnosing HIV early changes everything. It prevents the virus from attacking your body, and it prevents it from spreading through our communities. All each of us has to do is step up and take a test. Changing history is that simple. Testing centers are available throughout the city, or just ask your doctor at your next regular visit. And if your doctor offers a test, say yes. It's just the responsible thing to do. Then, share the word. Tell people that HIV treatment has changed. Tell people that testing has advanced. Tell people that the entire approach to HIV is different now. Let them know that by choosing to take a test, we can all end HIV. This is a fact. We are so close. Right here in Vancouver, we can be the epicenter of a movement that will change our city, that will change the world, that will change history. The beginning of the end of HIV. But to become we've got to have you. We need you to do your part. We need you to share the word, take the test, join the movement. End HIV. Change history. Learn more at itsdifferentnow.org.